بسم الله الرحمن الرحيم وبه نستعين. أنا الدكتور أنس عكور، أخصائي طب الطوارئ والحوادث والسموم السريري في كلية الطب جامعة العلوم والتكنولوجيا الأردنية. اليوم موضوعنا عن how to approach a patient complaining of dyspnea أو shortness of breath. طبعا الأوبجكتيفز لها البرزنتيشن إنه نعرف كيف البرزنتيشن لللايف ثريتنينج كونديشنز اللي بتيجي في shortness of breath، من ضمنها الأكيوت pulmonary edema، أزمة، COPD exacerbation، أيضا الpulmonary embolism. طبعا راح نمر على المانجمنت والبرزنتيشن ل each one of these pathologies. Okay, so what is dyspnea? أعتقد you are familiar with the term dyspnea. Basically معناه إنه في shortness of breath، وإنه it's like subjective sensation of difficult, uncomfortable or labored breathing. المريض في الطوارئ بيحكي لك إنه I can't catch my breath أو مش قادر أتنفس، حاسس حالي مخنوق. كلياتها عبارة عن terms إنه المريض عنده shortness of breath or dyspnea. طبعا في عندنا بعض التيرمز اللي لازم نكون عارفينها ونكون aware of them. عندنا أول مصطلح اللي هو التاكيبنيا hyperventilation، والمصطلح الثالث هو الارتيريال بلاد جاز. التاكيبنيا basically معناته إنه المريض breathing faster than the normal rate. طبعا الأدلت لحد 18 أو 20، أكثر من ذلك بيكون المريض تاكيبنيك. المصطلح الثاني اللي هو الهايبرفنتيليشن، basically معناه إنه المريض عم بتنفس deeply and or rapidly. بالنسبة للarterial blood gas, this is like a blood test. We usually do it in the emergency department just to assess the level of oxygen and the level of carbon dioxide in the blood. بالتالي بعرف إنه هذا المريض عنده respiratory failure type 1 ولا type 2، بالتالي بقدر أحدد شو المانجمنت المناسب لهذا المريض. Okay, so when does dyspnea occur? طبعا يا شباب احنا dyspnea is very common presentation or presenting complaint in the emergency department of every age. والcauses طبعا vary widely، فممكن يتراوح من benign self-limiting conditions to critical pathology that can produce short-term mortality and long-term morbidity. في بعض التيرمز اللي مرتبطة في بالshortness of breath، منها الديسنيا on exertion، في عندنا الأورثوبنيا والباروكسيمال nocturnal dyspnea. Basically الديسنيا on exertion، أول مصطلح اللي هو الديسنيا on exertion أو اللي بنسميها exertional dyspnea. طبعا هاي عبارة عن shortness of breath provoked by physical effort or exertion. طبعا احنا بالعادة بنستخدم quantitative terms، مثلا بنحكي للمريض how many مثلا أو the number of stairs or the number of blocks you can manage before the onset of shortness of breath. المصطلح الثاني اللي هو الأورثوبنيا، simply it means اللي هي difficulty breathing when lying down flat. And the same thing we can use quantitative measure for to assess orthopnea, such as how many pillow does you use on sleeping or when you sleep. بينما البي ان دي الباروكسيسمال نوكتورنال dyspnea هي عبارة عن sudden shortness of breath بتصير while sleeping at night. طبعا بالعادة بتدل على وجود congestive heart failure. نيجي على أول pathology that can present with shortness of breath which is asthma. So إحنا اللي بيهمنا هنا هو الأزمة exacerbation، لكن briefly نحكي عن الأزمة. طبعا هي عبارة عن diffuse airway inflammation caused by a variety of triggering stimuli resulting in partially or completely reversible bronchoconstriction. طبعا diagnosis للأزمة بيعتمد على الهيستوري والphysical examination بالإضافة لذلك الpulmonary function test. الأزمة involves four things or four pathophysiology. It involves bronchoconstriction and airway edema and inflammation, airway hyperreactivity, and airway remodeling. في عندنا common triggers of an asthma exacerbation include environmental and occupational allergens. في عندنا مثلا cold air or dry air، في عندنا الانفكشنز، عندنا الاكسرسايز، عندنا بعض الانهيلد irritants، بعض الدراجز مثل الانسيد والاسبرين، مرات الجاستروesophageal reflux disease can exacerbate asthma. Signs and symptoms of asthma exacerbation. Usually those patients present with shortness of breath, with chest tightness, audible wheeze and coughing. وغالبا الساينز راح تكون كمان visible for you، مثل الويزنج on auscultation، أيضا pulsus paradoxus اللي هي عبارة عن fall of systolic blood pressure أكثر من 10 mm mercury during inspiration. بالإضافة المريض لما تطلع على الفيتال ساين راح تلاقي المريض tachycardic, tachypneic. Sometimes the patient can't complete one sentence. Also all of these things like signs of asthma exacerbation. بالإضافة إلى ذلك مرات تلاحظ إنه في efforts to breathe مثلا using the accessory muscles. في حالات السيفير asthma exacerbation and impending respiratory failure، راح تلاقي في عنده المريض عنده altered level of consciousness، بتلاقي في عنده cyanosis، تلاقي المريض sometime bradycardic. All of these things can indicate severe asthma exacerbation or impending respiratory failure. طبعا بالإضافة لذلك للهايبركابنيا and hypoxia. Okay, in asthma exacerbation, we need to think about differential diagnosis. So there is a lot of cases or a lot of pathologies that mimic asthma. So those what we call asthma mimickers. مثال على ذلك عندنا acute heart failure, cardiac asthma، في عندنا upper airway obstruction، في عندنا pulmonary embolism، في عندنا aspiration of foreign body or gastric acid. Also, we have tumors or disorder causing endotracheal or endobronchial obstruction, interstitial lung disease, and also vocal cord dysfunction. All of these cases can mimic asthma exacerbation. Classification of asthma exacerbation. طبعا عندنا several score used for assessment of asthma exacerbation. واحد من هذا السكور راح نستخدمه اللي هو based on the 2007 National Asthma Education and Prevention Program guideline. Okay. Asthma exacerbations are classified as mild, moderate, severe, or life-threatening based on symptoms, clinical sign, and objective measurements such as oxygen saturation and peak flow expiratory rate. مثلا هون عندنا mild exacerbation usually present with dyspnea on exertion. The patient can speak in full sentences. Wheeze is mild or minimal, and the PEFR or peak flow expiratory rate is above 70%, predicted with oxygen saturation above 95. Whereas moderate exacerbations characterized by dyspnea at rest, speaking in phrases, increased work of breathing, sorry, and the peak flow expiratory rate between 40 and 69%, with oxygen saturation typically between 90 and 95. بينما severe exacerbations present with marked breathlessness, inability to complete sentences, tachycardia, accessory muscle use, and the peak flow expiratory rate راح يكون أقل من 40%, often accompanied by oxygen saturations below 90%. Whereas life-threatening asthma is identified by features such as silent chest, altered consciousness, exhaustion, bradycardia, or sign of respiratory failure, with peak flow expiratory rate less than 25%. So the key message here is that worsening symptoms, increasing work of breathing, declining PEFR, and failing oxygen saturation, all of these things indicate progression toward life-threatening disease and the need for urgent escalation of the treatment. Again, this is asthma severity assessment using symptoms, physical sign, or examination, and objective measures. The same thing for asthma severity assessment. Management of acute asthma exacerbation in the emergency department focuses on oxygenation, bronchodilation, and early anti-inflammatory treatment. First of all, supplemental oxygen should be administered to maintain oxygen saturation level above 90%. Secondly, inhaled bronchodilators are the cornerstone of treatment. Short, short-acting beta-2 agonists, methylsalbutamol, are given initially, and nebulized ipratropium bromide may be added later on in moderate to severe attacks, or when the response to beta-2 agonist is suboptimal. Third, systemic corticosteroids should be administered early in all patients. And in patients with refractory or life-threatening asthma, additional therapies such as intravenous magnesium sulfate and epinephrine may be required. If the patient's condition continues to deteriorate despite aggressive medical therapy, non-invasive ventilation may help reduce the work of breathing, while endotracheal intubation and mechanical ventilation may be necessary in cases of impending respiratory failure or established respiratory failure. Okay, so the key message here is treat asthma exacerbations with oxygen, bronchodilators, and steroids early, then escalate to magnesium sulfate, either orally or using intravenous route, with or without epinephrine, and sometime or in refractory cases, consider ventilatory support for those cases. Status asthmaticus refers to a severe asthma exacerbation that is refractory to the standard treatment اللي هن inhaled bronchodilators and corticosteroid. طبعا هي life threatening condition وكان progress rapidly to respiratory failure and then cardiopulmonary arrest if not treated well. Now the cornerstone of management is rapid and aggressive bronchodilator therapy. طبعا مع إعطاء المريض السيستميك corticosteroid. طبعا إذا المريض fail to respond adequately فلازم هنا نقرر أو نعطي المريض several adjunct therapies مثل intravenous magnesium sulfate and sometimes NIPS أو nebulized magnesium sulfate. ممكن نضيف كمان الكيتامين الإبنفرين also we can use it. أو ممكن نختار كمان non-invasive positive pressure ventilation. However, if the patient develops like worsening hypercapnia, acidosis, exhaustion, altered mental status, or impending respiratory arrest, هنا لازم تعمل للمريض endotracheal intubation with mechanical ventilation. فالكي مسج هون إنه الستاتس asthmaticus هي medical emergency requiring early escalation of therapy to prevent respiratory failure and cardiopulmonary arrest. COPD exacerbation or chronic obstructive pulmonary disease exacerbation. طبعا احنا بنعرف السي او بي دي هو عباره عن chronic inflammatory lung disease characterized by persistent airflow limitation which most commonly caused by cigarette smoking. طبعا عندنا less common causes مثل الالفا 1 antitrypsin deficiency and occupational exposures. Those patients with acute COPD exacerbation typically present with worsening shortness of breath, worsening cough, increased sputum production, change the color of the sputum into green, for example. Also on examination, there's some findings you might pick it up, like wheeze or reduced breath sound and prolonged respiratory phase. Severe disease may be complicated by pneumothorax, right heart failure, and recurrent exacerbations, and acute or chronic respiratory failure. Management focuses on the three immediate goals, اللي هي maintaining oxygen, adequate oxygen level, reversing airflow obstruction, and treating the underlying cause. طبعا treating هون هو similar to asthma exacerbation، لكن مهم جدا نخلي في بالنا انه target our target in oxygen saturation should be between 88 to 92%. طبعا in addition to bronchodilator and systemic corticosteroid and antibiotic when infection is suspected. طبعا إذا كان المريض عنده respiratory failure هنا you need to consider non-invasive ventilation, and sometime in severe cases you need to consider endotracheal intubation with mechanical ventilation. So unlike asthma, oxygen in COPD should be carefully titrated with a target saturation of 88 to 92%. الفكرة كلياتها إنه just to avoid worsening hypercapnia in susceptible patients. Acute pulmonary edema عبارة عن acute left ventricular failure causing increased pulmonary venous pressure and fluid accumulation in the alveoli. Patients present with sudden severe dyspnea, cough with pink frothy sputum, diaphoresis, bilateral crackles, and sometimes wheeze. طبعا في many causes for such condition لكن the most common is acute coronary syndrome, heart failure, arrhythmias, and fluid overload. So just remember it is a medical emergency requiring rapid recognition and treatment. اوكي مثل ما حكينا الاكيوت pulmonary edema هي ميديكال emergency. طبعا السبب بيكون acute left ventricular failure، هذا يؤدي بالنهاية للفلويد accumulation within the alveoli. حكينا عن الأسباب أو الكومن كوزز. احنا حكينا أهمها هو الأكيوت كوروناري سيندروم، لكن خلي بالك ممكن يكون acute decompensated heart failure, arrhythmia, valvular heart disease, volume overload, or حتى medication and adherence may also all of these things contribute to this condition. الكي مسج هون إنه الأكيوت pulmonary edema result from left or acute left ventricular dysfunction تعمل alveolar flooding تؤدي بالنهاية إلى severe hypoxia and respiratory distress. Okay, so this chest X-ray for a patient with acute pulmonary edema. So if you look here, there's like cardiomegaly for in this X-ray. There is some pleural effusion on both side, and there is high lung congestion as shown in this X-ray. So this is cardiogenic pulmonary edema. So there's a sign, so what we call like bat wing or butterfly sign. So it's basically bilateral perihilar patchy opacities. Okay, so there is many findings on chest X-ray for patient with acute lung, uh, acute pulmonary edema. So the first one is pulmonary vascular congestion, and the second one is cephalization. Third one is peribronchial coughing. Fourth one is increased interstitial marking. And don't forget curly B line. Also the fluffy alveolar opacities. Number 7 is pleural effusion. And the last X-ray finding is enlarged cardiac silhouette. Okay, so this chest X-ray shows most of the chest X-ray finding as described in the previous slide. And on the left side, this is like a CT scan of the chest. Shows like there is some alveolar infiltration or opacities on both sides. Also, there's like interstitial edema. So this is concerning for acute pulmonary edema. Okay, so diagnosis of pulmonary edema, mainly it's a clinical diagnosis. So just by history and physical examination, you can reach the main diagnosis, and it's supported by the findings on chest X-ray. But sometimes you can request some few investigations مثل الكاردياك enzyme blood test مثل الكدنey function test, liver function test, full blood count, inflammatory markers, also brain natriuretic peptide. طبعا هذول مهمات جدا في الانفستيجيشن. طبعا ما تنسى الاي سي جي والاي بي جي لانه هذول مهمات جدا في الاسسمنت اوف ذا بيشنت، وانك تعرف شو الاندرلاين كوز، لانه حكينا احنا الموست كومن underlying cause for acute pulmonary edema is acute coronary syndrome. So that's why you need to do ECG for such patients. البي ان بي بيساعدنا انه نميز انه هل الاكيوت ديسنيا اللي عندي في الطوارئ Is it from like pulmonary system or cardiac system؟ في حالات السي او بي دي اكسسبريشن البي ان بي راح يكون نورمال طبعا most of the time، وفي حالات البلمونري إديما راح يكون high elevated. Okay. Okay, so the management of acute pulmonary edema is usually ABCDE approach, and the specific treatment for acute pulmonary edema always start with oxygen, as those patients usually hypoxic, so you need to start oxygen therapy for such patients. بعدين consider IV diuretics لأنهم المريض بيكون عندهم fluid overload. consider nitrates إذا كان البلد بريشر عالي كثير. إذا كان المريض أو البلد بريشر للمريض عنده واطي كثير، فكر في cardiogenic shock و consider IV inotropes. طبعا don't forget other options we can use in emergency department مثل ال CPAP و sometime ال endotracheal intubation with mechanical ventilation. طبعا في بعض السبيسيفيك تريتمنت اللي هي additional treatment اللي نقدر نستخدمها في الاكيوت pulmonary edema، لكن بيعتمد على الايتيولوجي. فمثلا اذا كان مريض او اذا كان السبب هو acute myocardial infarction، if you need to consider thrombolysis or ال PCI. إذا كان السبب هو severe hypertension consider IV vasodilator. إذا كان السبب هو abnormal erythemia or dysrhythm so consider direct current cardioversion مثل ال supraventricular tachycardia or VTAC. بهالحالات you need to cardiovert them. أما for example إذا كان المريض عنده rapid atrial fibrillation لكنه stable نوعا ما، وبدك يعني just to control the ventricular rate either immediately or later on، بتقدر تعطي digoxin for such cases. Okay, so let's move on to another topic, which is pulmonary embolism. I think you are familiar with pulmonary embolism as you saw many patients during your internal medicine round during your fourth year medical school. طبعا it's difficult to diagnose لأنك صعب تستخدم just the clinical symptoms أو the clinical examination to exclude or to rule in pulmonary embolism. طبعا في شيء بنسميه الفيرتشوز ترياد اللي هي عبارة عن three factors contributing to the development of thrombosis in our vessels اللي هن الفينوستاسيس، الهايبركواجيبيليتي and visual wall inflammation. طبعا we have two type of pulmonary embolism حسب الكوز. في عندنا ال provoked pulmonary embolism، في عندنا ال unprovoked pulmonary embolism. ال provoked pulmonary embolism هي عبارة عن إنه PE مرتبطة مع risk factors مثلا trauma، مثلا surgery، pregnancy. all of these things can provoke pulmonary embolism. ال unprovoked pulmonary embolism يعني هي عبارة عن pulmonary embolism بس ما لقيت في underlying cause or underlying risk factor. Again, this is like a summary for Virchow's triad and the definition of pulmonary embolism. The clinical features of pulmonary embolism, then most of the patients present with dyspnea, as estimated 70% of patients. طبعا the second thing is tachypnea, and many patients complain of pleuritic chest pain, also apprehension, tachycardic, also cough, and few of them may complain of hemoptysis, leg pain, clinically even DVT in 10% of patients. So some major risk factor and minor risk factors for PE. As we said, surgery is a major risk factor for PE. Also, like late pregnancy, cesarean section, also like fractures, malignancies, reduced mobility. All of these things are considered as a major risk factor for pulmonary embolism. Whereas there is some minor risk factors that might contribute to pulmonary embolism مثل congestive heart failure، مثل oral contraceptives، مثل COPD. All of these things might contribute to the development of pulmonary embolism. Okay, so when you encounter a patient with sudden shortness of breath and you suspect PE, So you need to do or to run like a risk assessment for such patient. واحدة من الريسك assessment اللي هو بنسميه الويلز سكور. طبعا هذا الويلز سكور في عندنا بعض الكرايتيريا وفي عندنا بعض البوينتس. فإذا كان المريض عندنا low risk for PE, then there is some approach for such patient. إذا كان intermediate or high risk مثلا, you need to consider another approach for such patients. فعلى سبيل المثال إذا كان المريض إنه low risk for PE, so just simply send the dimer. So if the dimer is negative, then it is unlikely that there is DVT or PE. إذا كان المريض at intermediate risk or high risk, ما في داعي تودي دي dimer. So just scan such patients either with CT pulmonary angio or VQ scan. Few investigation that can be requested for pulmonary embolism عندنا مثلا chest X-ray, ECG and CT pulmonary angio. طبعا chest X-ray usually normal in pulmonary embolism, لكن مرات بتشوف بعض الساينز, ومن هاي الساينز اللي بتشوفها هنا مثلا عندنا في عندنا focal peripheral wedge shaped opacity, هاي بنسميها الهامبتونز hump. تمام. لكن في بعض and there is other signs you can notice once reading chest X-ray. لكن most of the time the X-ray will be normal. لكن ممكن تشوف مثلا small pleural effusion, elevated hemidiaphragm. أيضا ممكن تشوف شيء بنسميه Wester mark sign اللي بتكون due to reduced pulmonary vascular marking. هذول معظم الساينز اللي بنشوفهم in case of pulmonary embolism. بالنسبة للإي سي جي, طبعا في عندنا كلاسيك ساين بنشوفها في حالات البلمونري امبوليزم, لكنها uncommon finding اللي هي الاس 1 كيو 3 تي 3. طبعا بيكون عندنا deep S wave in lead 1, Q wave in lead 3 and inverted T wave in lead 3. لكن most of the time most common finding is sinus tachycardia. لكن ممكن تشوف كمان انه signs of right heart strain, زي right axis deviation, مثلا زي right bundle branch block, مثلا T wave inversion من in V1 to V4. ممكن تشوف مرات P pulmonal. طبعا this is a CT scan for patient with pulmonary embolism. So here نسميه احنا diffusion or filling defect, and this indicates pulmonary embolism. This is the main learning points for this presentation. Please read them, and thank you.